Good evening, everybody. I, Dr. Avya Bansal, consultant chest physician at Bombay Hospital, Mumbai, proudly welcome you to this webinar organized by Chest Council of India in association with CIPLA. I would like to thank and express my gratitude to CCI for giving me this opportunity to moderate and present this session. I thank our CCI office bearers, Dr. Narendra Sir, Dr. Ravi Doshi Sir, our CCI National Coordinator, Dr. Chenam Chetty Sir, and our CCI Chairman Trustees, Dr. Narayana Pradeepa Sir and NH Krishna Sir. The topic for today's masterclass on suppurative lung diseases is bronchiectasis, and the topic master is none other than Dr. G.K. Paramjyoti Sir. Dr. Paramjyoti Sir needs no introduction in the field of pulmonology. He has completed his MBBS and MD from Osmania Medical College, Hyderabad. He currently serves as professor and head of department and associate dean at the Nizam's Institute of Medical Sciences, Hyderabad. Sir has numerous students graduated under his aegis. He has a keen interest in allergy, asthma, interstitial lung diseases, and tuberculosis. He is the proud recipient of the Fellowship of American College of Chest Physicians. He has published more than 20 national and international index journal articles. He is a member of more than 9 international and 8 national chest societies. I open this session and hand it over to Paramjyoti Sir for what I believe would be an enchanting and wonderful session on bronchiectasis. Thank you.
Good evening, everybody. At the outset, I would like to thank Dr. Krishna, the president of CCI, Dr. Vijay Kumar Chennam Shetty, and all the office bearers of CCI for giving me this opportunity to speak on this topic of bronchiectasis in adults. And this is a moment that I'm going to cherish because it's a privilege that I have and a moment that I'm going to cherish it for a long time to come. So my topic today would be bronchiectasis in adults, and I'm going to limit myself to non-cystic fibrosis bronchiectasis in adults. And I'll start with a case that we have recently discussed as a CPC case. It was a 21-year-old student, male, with a background history of recurrent respiratory tract infections since childhood, chronic bronchiectasis and sinusitis, came with the symptoms of progressive paresthesias, both upper and lower limbs, 3 months duration, weakness involving all 4 limbs for the last 10 days, and with intermittent fever and loss of appetite. He underwent left lobectomy in the year 2003 and right lobectomy in 2014, underwent FACED in 2017. On examination, he had pallor, icterus, clubbing, bilateral lung coarse crepitations, hepatosplenomegaly. He was given IV immunoglobulins in a center outside of our institute with a clinical suspicion of Guillain-Barré syndrome. In spite of IVIG replacement, he did not improve. That's how he came to our institute. On investigations, he had pancytopenia, elevated liver enzymes, reduced albumin, increased APTT, increased alkaline phosphatase and LDH, reduced immunoglobulins. However, IgI were normal, probably because he was given IVIG. Outside the hospital, CD19 cells were reduced. Epstein-Barr virus immunology, IgM, IgG were positive, and a nerve conduction study suggestive of demyelinating neuropathy with conduction blocks. Ultrasound abdomen, there was splenomegaly with fatty liver and non-obstructive renal calculus. CT chest showed bilateral bronchiectasis. And to cut the long story short, he underwent sural nerve biopsy and bone marrow biopsy. Both of them showed T-cell lymphoproliferative disorder, that is T-cell lymphoma. And this is the evolution of his disease. He was respiratory symptomatic since his childhood with recurrent respiratory infections. And then once he had bronchiectasis, and as a child, he underwent a lobectomy in 2003, and then another surgery on the other side in 2014 FACED. And then following repeated infections, he developed infections due to Epstein-Barr virus related Epstein-Barr virus infections, and now he has ended up with a lymphoproliferation due to immune suppression, Epstein-Barr virus infection, and T-cell lymphoma. If only this boy had the cause of his recurrent infections investigated when he was a child, possibly or probably maybe we could have avoided all these events. Now I'm going to my topic straight away. My topic, as I have already told you, it is bronchiectasis in adults, non-cystic fibrosis. I'm going to discuss this topic under so many headings. To begin with, bronchiectasis has been recognized as a major clinical problem since its first description by the French physician René Laennec in 1819. It is derived from a Greek word which means bronchi, denoting branches of the main bronchus. Ectasis means dilatation. Thus, bronchiectasis is a chronic, progressive in some of the conditions, especially if there is a severe dyskinesias or immunoglobulin primary immune deficiencies and irreversible dilatation. But however, it could be reversible, especially in pediatric group and even in adults. There is some irreversible case reports documented in bronchiectasis. So patients with bronchiectasis have structural defect in the form of dilated airways. Of course, there are many endotypes and phenotypes that we are going to discuss later on, and there are involvement of overlap states. Thus, it is a pathological or a radiological term, meaning there is a structural airways disease in the form of dilatation of airways. And clinically, bronchiectasis patients, by and large, present with a clinical syndrome of cough, sputum production, and bronchial infection for a long time. So, thus, there is a chronic respiratory disease in these patients, and some of them present with breathlessness and sinusitis, fatigue, hemoptysis are some of the other clinical manifestations in addition to thoracic pain. Coming to the epidemiology, as compared to the Indian population, the European population people are little older, and females are more in Europe and North America as compared to males. The average age in India is 56 years as compared to Europe and North America, which is 65 years. And it is more seen in non-smokers, 71% in India, 60% in Europe and North America. Prevalence-wise, in more than 40 years of age, bronchiectasis, we have data from China which says for every 1 lakh population, there is a prevalence of 1,200 as compared to Western population where it is only 566 per lakh population. 34% of bronchiectasis patients do not have comorbidities. However, a majority of them do have a number of comorbidities. Now, according to the Indian Bronchiectasis Registry, the underlying causes of bronchiectasis are infective, predominantly tuberculosis and non-tuberculosis, and then idiopathic. And allergic bronchopulmonary aspergillosis also constitutes a major chunk of the causes of bronchiectasis in India. The bronchiectasis that is seen in Indian population, again from the Indian Bronchiectasis Registry, is the disease is bilateral, more common in lower lobes, middle lobe and lingula, and then in upper lobes. And cystic type of bronchiectasis is more common as compared to varicose or cylindrical. And lung functions wise, normal spirometry, restrictive and obstructive patterns are documented in Indian population. And as you can see, bronchiectasis is seen throughout the globe. That is, it's a global disease. And etiology wise, again, idiopathic and post-infective bronchiectasis are more common worldwide. One center in US has more of immune-related bronchiectasis. Aging and its impact on bronchiectasis, as we have seen, this disease of bronchiectasis seems to be increasing with increasing of age, because, and it has been observed that with increasing age, there is increase of prevalence of bronchiectasis. Particularly severe form of disease is more in elderly people with an atypical presentations, and the outcomes are poor as compared to younger cohorts. Subclinical microaspiration, including the nasopharyngeal microbiota, could be one of the reasons for this incidence. The variations in immune and micro signatures in elderly people constituting what is called as immune senescence could be one of the factors for increased incidence of bronchiectasis in elderly patients. So you have n number of reasons for elderly people to develop bronchiectasis: immunosenescence, telomere dysfunction, and all the signaling pathways favoring inflammation and airway destruction. And since some of the elderly patients are also on immunosuppression, and immunosuppression leads to recurrent infections, and bronchiectasis could be few other reasons for increasing prevalence of bronchiectasis in elderly age group. Now, the airway of a bronchiectatic airway is pathologically there is loss of cilia, increased mucus, and then there is destruction of the wall of the airways. And as per according to the Reed's classification, they are either cylindrical, varicose, or cystic bronchiectasis. Now, coming to the pathogenesis of bronchiectasis, this is the Cole's vicious cycle hypothesis. Once microbes come into the airways and they colonize, they set up infection in the airways, there is inflammatory neutrophilic inflammation predominantly, and these neutrophils release neutrophil elastases, and in addition to elastases, they secrete some other inflammatory products that will come to it later. So once neutrophilic inflammation will cause chronic infection, increase inflammation, and that's going to cause structural damage to the airways, resulting in a loss of cilia, mucociliary function, destruction of the bronchial wall, resulting in bronchiectasia, mucus retention. Thus, there is an anatomic distortion. Then there is lung injury, both to the airways and to the parenchyma, mucus insufficiency, retention, plugging, impaired mucociliary clearance, innate and adaptive immune deficit, and this cycle goes on. This is called the vicious cycle hypothesis of Cole. And once we have done with Cole's vicious cycle hypothesis, we'll go on little further about the neutrophils. Now, this is a paper published in American Journal of Respiratory Critical Care Medicine in 2018. This says that in bronchiectasis, even in stable state patients, peripheral neutrophils are reprogrammed and have prolonged survival, and there is impairment in their functional ability of their bacterial phagocytosis and killing, thereby perpetuating the vicious cycle in bronchiectasis. Meaning, there is a neutrophil paradox. Even though the neutrophils are more in number in the airways, however, still they are not effective in their ability to kill the bacterial pathogen. Not only elastasis, not only the neutrophil paradox, neutrophils also release what is called neutrophil extracellular traps. These are called nets. Nets are composed of DNA and histones and over 30 granular proteins, and these nets are responsible for so many pathologies in the lung, including tissues, cell damage, delay in tissue repair, inflammation, autoantibody production. So then we'll go on to the next neutrophil product, that is called pregnancy zone protein, that is secreted exclusively in the airways of bronchiectasis patients. So in addition to the elastasis, in addition to the neutrophil extracellular traps, neutrophils of bronchiectasis patients also secrete what are called pregnancy zone proteins. Now, what are these? Pregnancy zone protein is a protein that is usually seen in pregnant women, and this causes immune tolerance so that the fetus is not rejected. And the same thing is secreted by neutrophils in the bronchiectatic airways. Thus, there is immune suppression due to the T lymphocyte function is reduced, and then there is depression of IL-2 production. So you have neutrophil elastasis, you have neutrophil extracellular traps, you have neutrophil paradox, and you have pregnancy zone protein released by the neutrophils. All these put together will cause what is called it will set up what is called a vicious vortex in the causation of bronchiectasis. So the tetrad of events, that is the infection, inflammation, epithelial ciliary dysfunction, mucus hypersecretion, bronchiectasis, all of them interact with each other in multiple directions, along with neutrophil paradox and pregnancy zone protein, result in poor airway clearance, perpetuating chronic infection and inflammation, airway epithelial cell and ciliary dysfunction resulting in bronchiectasis. So this is again the same model describing the pathogenesis of bronchiectasis according to the vicious vortex model. The neutrophilic inflammation has an interaction with epithelial dysfunction, mucus hypersecretion, ciliary dysfunction. Neutrophils interact with lung destruction. Neutrophils cause chronic infection and bacterial virulence. The the neutrophil paradox, because of the neutrophil paradox, they are not able to eliminate the colonizing pathogenic bacteria, and the link between neutrophils and immune tolerance possibly could be the pregnancy zone protein, and thus pregnancy zone protein may therefore provide a novel link between chronic neutrophilic inflammation and impaired host immunity to infection exclusively in patients with adult bronchiectasis. Now, there are many number of causes for causation of bronchiectasis. Now, the commonest one are idiopathic and post-infectious bronchiectasis. And among the infections, tuberculosis in our country is more common, and non-tuberculous mycobacteria are more in American continent, and of course bacteria. Other bacterial infections are also responsible for causation of bronchiectasis among the post-infectious causes. In the immunodeficiency, we have common variable immunodeficiency or selective IgA deficiency. These are all the primary immunodeficiency disorders that can cause recurrent respiratory infections and then bronchiectasis. And impaired ciliary clearance, as is seen in cystic fibrosis or primary ciliary dyskinesias or Young syndrome, connective tissue and inflammatory disorders like rheumatoid arthritis, Sjogren's, and allergic conditions like ABPA, or traction bronchiectasis that is seen more in post-TB that in our country, of course, and sarcoidosis and fibrotic interstitial lung disease also cause traction bronchiectasis. Mechanical obstruction due to either foreign body or a tumor or an extrinsic compression or a stenosis of the airway also can cause bronchiectasis. And aspirations, alpha-1 antitrypsin deficiency, yellow nail syndrome, diffuse pan-bronchiolitis, toxic inhalations, all of them can cause. So there are many number of reasons for the causation of bronchiectasis in an adult patient. And as I've already told, the idiopathic and post-infectious bronchiectasis constitute the major chunk of bronchiectasis throughout the globe. So patients with bronchiectasis and sinusitis, the cause could be cystic fibrosis, primary ciliary dyskinesias, Young syndrome, diffuse pan-bronchiolitis, ABP, allergic fungal sinusitis, and common variable immunodeficiency, Good syndrome, and autoimmune hyper-IgE syndrome, that's called Job syndrome. Bronchiectasis with infertility or reduced fertility is seen in cystic fibrosis, primary ciliary dyskinesias, and Young syndrome. So the phenotype that is we have many phenotypes even in bronchiectasis, not just exclusively in other COPD or asthma patients. The definition of COPD, that is the definition of phenotype that is given for COPD, was originally proposed by Hans and colleagues, and the same definition can also be applied to the bronchiectasis patients. Using a multidimensional clustering complex statistical method, the phenotypes, the clustering of the patients were classified into various groups, and in 5 European databases involving 1,145 patients prospectively, there were 4 different groups, phenotypes that were described. Same from the Spanish group, another 4 different phenotypes. From the Chinese cohort, another 4 different phenotypes. So you have multiple phenotypes, multiple clustering phenotypes due to the cause could be different, the presentation could be different, radiological could be different, clustering is different. So you have multiple phenotypes in bronchiectasis. Now, let's go to the endotypes. Now, endotypes are also described in idiopathic bronchiectasis patients or patients with pulmonary NTM infections. The endotypes that are responsible for idiopathic bronchiectasis or pulmonary non-tuberculous mycobacteria are thought to be due to a variance of ciliary dysfunction or a variance in the immune dysfunction or various variant connective tissues or cystic fibrosis variants. So these are the different endotypes that are described in idiopathic pulmonary fibrosis, and in days to come, possibly we are going to treat these patients based on phenotypes and endotypes. So most of these patients of bronchiectasis present with cough, sputum, more excessive sputum volume, hemoptysis, dyspnea, chest pain, recurrent chest infections, and the signs are they could be normal or they can have clubbing, crackles, coarse crepitations, and wheeze in about 21% of the patients. Since cough and sputum are the predominant and common symptoms of bronchiectasis, this is the Murray sputum chart described by Murray way back in 2009. According to this chart, the more the purulence of the sputum, more the chances of culturing a pathogenic bacteria from the sputum of these patients. And this was validated recently in Italian Registry of Bronchiectasis, wherein they have found that more the purulence of the sputum, more the bacterial infection, more, and Pseudomonas aeruginosa infection is more isolated from purulent sputum. These are the patients who have poor lung functions. The severity of BSI or the bronchiectasis severity index is more, quality of life is poor, hospitalizations are more, and exacerbations are more as compared to patients who have the mucoid sputum. So the gold standard in the diagnosis of bronchiectasis, apart from clinical features are not very specific for bronchiectasis. However, chest X-ray gives some clue about bronchiectasis for sure, but as on today, HRCT is the gold standard in the diagnosis of bronchiectasis, and the CT features of bronchiectasis was given to us by Neidig way back in 1982, and bronchiectasis is defined by bronchial dilatation as suggested by one or more of the following. When the bronchial arterial ratio is more than 1, lack of tapering or airway visibility within 1 centimeter of costal pleural surface or touching the mediastinal pleura. The following indirect signs are commonly associated with bronchiectasis, that is bronchial wall thickening, mucus impaction, mosaic perfusion, air trapping or expiratory CT, and emphysema. So this is what it means. For bronchiectasis, the airway should be dilated as compared to the adjacent pulmonary artery, and the wall also should be thickened. So it should be dilated and the wall should be thickened. Only then we can label this as bronchiectasis. So chest X-ray, you could see tram lines or finger in glove appearance, but or the loss of volume in middle lobe with bronchiectasis. So, but CT scan, as I told you, is a gold standard in the diagnosis. You could have a cylindrical bronchiectasis, varicose bronchiectasis, cystic bronchiectasis, and finger in the signet ring sign that we see with the airway accompanying the pulmonary artery is bigger than the artery. We call it as cystic bronchiectasis. And the morphologically, they could be either cylindrical bronchiectasis, varicose, and cystic bronchiectasis as given to us by the previously. So basing on the distribution of the bronchiectasis, we can assess the cause of the bronchiectasis. If it is diffuse bronchiectasis, apical predominance is in cystic fibrosis and sarcoidosis, anterior predominance in infection due to non-tuberculous mycobacteria or ARDS, basal predominance due to ciliary dyskinesias or recurrent aspirations or immune suppression, and without any regional predominance, you have in Mounier-Kuhn or Williams-Campbell syndrome. Central bronchiectasis in ABPA and focal bronchiectasis could be due to either foreign body or bronchial stenosis or a tumor or excessive compression. So this is a 58-year-old woman with chronic cough of several years duration. Here we can see bronchiectasis is confined to the lingula and middle lobe. This is typical of NTM infection. Bronchiectasis due to NTM infections. This is again a 67-year-old male with history of hiatus hernia, recurrent pneumonias with hiatus hernia and bronchiectasis predominantly lower lobe. This is bronchiectasis due to recurrent aspirations. So here you have a honeycombing and then traction bronchiectasis. So this is a traction bronchiectasis in usual interstitial pneumonia pattern. Tracheobronchomegaly, roomy trachea with tracheal diverticula, and then bronchiectasis. It is Mounier-Kuhn syndrome. And this is again a 49-year-old woman with history of chronic cough and recurrent respiratory infections. Bronchiectasis that is with a normal trachea size and no circulations, but with the characteristic central bronchial bronchiectasis that is seen in William-Campbell syndrome. And ABPA, we have fingering glove and hyperattenuating mucus. And this is due to focal stenosis bronchiectasis. And this is bronchiectasis in post-tuberculous fibrosis. And this is a bronchiectasis in a patient who has sinusitis and infertility in Young syndrome. This is a patient with bronchiectasis with situs inversus sinusitis. This is cardiovascular syndrome, severity, kinesis. Now, having described about the CT features, we'll go to the severity assessment using CT scan. So, the first CT scoring for bronchiectasis was given by Meenakshi Bhalla, and this was way back in 1991. And this was based on a retrospective study of 14 patients this was done in cystic fibrosis patients, and based on 9 parameters, the scoring was done, and the maximum score that one could give, the parameters are severity of bronchiectasis, bronchial thickening, and then the extent of bronchiectasis circulations. All these parameters put together, score is given, and this score is deducted from a score of 25, and the score that we get is the score of Bhalla scoring system. According to this Bhalla scoring system, though lower the score, severe is the disease. Now, another scoring system is modified Reiff scoring. The number of lobes are maximum 6, including the lingula. The severity of the bronchial dilatation with adjusted vessel, the bronchial wall thickening, type of bronchiectasis, lobar distribution, all taken into consideration, scoring done, and then the more the score, more severe is the bronchiectasis. Now, this having discussed about the severity according to CT scan, let's go to pulmonary functions. And we have seen in the Indian bronchiectasis registry, many of the patients have normal spirometry, and some of them have obstruction, and some of them have mixed. This is an interesting study that I have found. This is the data of bronchiectasis patients across European countries. About 187 patients of bronchiectasis were studied, and various severities and various demographics were included, various treatments were included, various microbes that were colonizing were included, and the plethysmography, DLCO, and spirometry was done in these patients. What they have found is the airflow obstruction alone was seen only in 3%. Air trapping was seen in plus obstruction in 38.1%. I mean, air trapping with obstruction, of course, it's a severe obstruction. Air trapping alone in 32.1%. And most of the obstruction was non-reversible, and only 9.7% of the bronchiectasis patients had normal lung function. Most of these patients had air trapping, diffusion impairment, obstruction, restriction, and hyperinflation. Now, this is an interesting graph. If only spirometry was done in these patients, 58.9% of the patients had normal spirometry. Air trapping, according to this study, was seen in 70.2%. But in this group, if only spirometry was done, 32.1% had normal spirometry. 55.7% had diffusion impairment, but spirometry was normal in 31%. So the point is, if you have to do a lung function test, from here on, maybe spirometry alone is not sufficient, because in 58.9% of patients, plethysmography and DLCO assessment detect lung function abnormalities that could have been missed with the sole spirometry. Air trapping and deacid impairment are the most common lung function abnormalities, and reversibility of residual volume is present in more than 1/4 of bronchiectasis patients with air trapping, while FEV1 reversibility is less frequently observed. So this is another index that is studied in cystic fibrosis patients, more in children. With this is based on multiple nitrogen washout method to detect early peripheral airways with greater sensitivity than spirometry. Maybe this also can be used for bronchiectasis, adult bronchiectasis patients. The complications of bronchiectasis, as we all know, it's either pneumonia, lung abscess, empyema, septicemia, hemoptysis, ABPA, carpal respiratory failure, amyloidosis with nephrotic syndrome, or recurrent pleurisy. The objectives of bronchiectasis workup are the objectives are to find the causes of bronchiectasis, to find out the treatable traits, to estimate the severity of the disease, to look for comorbidities or overlap syndromes, look for complications that are present, and look for surgical fitness if these are patients for surgery. So the diagnostic approach to these patients are to find the etiology of the bronchiectasis. So the minimum test that we should be doing are CBP, differential count, and total and specific IgE to aspergillus, immunoglobulins, sputum culture for bacteria and AFB, and also NTM if the suspicion is there, and then lung function tests and pulse oximetry look for hypoxemia, and little more tests to be done in those patients who are not responding or worsening. Bronchoscopy if there is a foreign body or a tumor or a stricture to identify, or to take bronchial washings for microbiology, or if you on bronchoscopy, if you see a roomy airways with the diverticula, then it's Mounier-Kuhn. So autoimmune workup, connective tissue panel, antibody response to proteins and polysaccharides if we are suspecting specific antibody deficiencies, and cystic fibrosis screening, and a primary ciliary dyskinesis screening, alpha-1 antitrypsin if there is a lower lobe emphysema, and bronchoalveolar lavage also for AFib and NTM cancers. So in addition to trying to identify the cause of bronchiectasis, we have to look for treatable traits in the management of bronchiectasis. The treatable traits could be pulmonary, like infections or mucus hypersecretions or eosinophilia, asthma, or there is bronchial hyperreactivity, or it could be extrapulmonary in the form of rhinosinusitis or GERD, cardiovascular disease, obesity, depression, or it could be environmental or lifestyle factors like smoking or exposure to air pollution and lack of exercise and lack of adherence to treatment. So these are some of the treatable traits that we have to actively look for in the management of bronchiectasis. So the treatable traits would be pulmonary or etiological, extrapulmonary or environmental lifestyle traits. If we treat this patient, we will have more good lung functions, increase the exercise capacity, reduce hospitalizations, increase the quality of life, reduce the exacerbations, increase the survival of these patients. Now we'll go to the severity estimation of bronchiectasis. So we have first and most important, very commonly used is bronchiectasis severity index. Again, various points are given, taking into consideration various parameters. About 9 parameters are taken from age, BMI, lung function to hospitalization, exacerbation, breathlessness, Pseudomonas, colonization, radiological severity, and then points are given. And the score is designed to predict future exacerbations, hospitalizations, health status, and death over 4 years. So if we look at it, if more the score, more is the severity, greater is the 1 year mortality, greater is the 1 year hospitalization, greater is the 4 year mortality, greater the 4 year hospitalizations. Here again, if you see, the greater the score, poor is the quality of life, greater the score, more the exacerbations, and greater the score, greater the hospital administration, greater the score, greater is the mortality. Now, the other score is FACED scoring. This is from the Spanish group. About 5 factors are taken into consideration: lung functions, age, colonization, radiological severity, and dyspnea. Again, scoring is given. Greater the score, greater is the 5-year mortality in these patients. And the FACED score and BSI, they almost correlate very well. because exacerbations were not considered in facet scoring, exacerbation facet scoring is another score that is given again by a Spanish group. The number of exacerbations were taken into account, and greater the score, greater is the severity of the bronchiectasis disease. So, as when BSI facet and exacerbation facet are compared, BSI is more sensitive. The sensitivity is more, however, specificity is less. Whereas facet and exacerbation facet, the sensitivity is low, but the specificity is more. There's another scoring system based on radiology, bronchial dilatation, and number of emphysema and number of bronchopulmonary segments. The scoring is given. Greater the score, greater is the severity. And as we can see, the greater the score, greater is the sputum purulence, and greater the score, poor is the lung function, greater the score, more are the hospital administration. So this is another score based on purely on CT scoring. But there is another score wherein the comorbidities are taken and then scores are given. This is again to predict 5 years future mortality and hospitalizations require exacerbations requiring hospitalization. Greater the score, greater is the 5-year mortality and hospitalization. Again, various the comorbidities are given various scores, and this score is correlating very well with BSI or facet scoring. Now, we will go to the pulmonary arterial hypertension in patients with bronchiectasis. The prevalence of pulmonary hypertension is still not well known. However, there is one study which showed that 33% of bronchiectasis patients have pulmonary arterial hypertension. Of course, that was a very small group. So, patients with pulmonary arterial hypertension, bronchiectasis patients with pulmonary hypertension are more hypoxemic, have greater number of involvements in lobes of lungs, have worse survival. MRC dyspnea score is an independent predictor of long-term survival, and there is RV dysfunction even without pulmonary hypertension in patients with pulmonary bronchiectasis with pulmonary hypertension. The patients with bronchiectasis also have increased risk of cardiovascular events like MI or stroke, and those patients who have more than 3 exacerbations per year or poor lung functions for male stand to have a greater risk of cardiovascular risk in patients with bronchiectasis. Now, coming to the management of bronchiectasis, the aims of management of bronchiectasis include to reduce exacerbations, to reduce the symptomatology, improve quality of life, limit the progression of disease, reduce lung function and lung function decline, and reduce the mortality. Now, how do we approach to the management of stable bronchiectasis approach would be the key management strategies are airway clearance, smoking cessation, vaccination, and antibiotics when there is an exacerbation of bronchiectasis. So you have if you have a high sputum burden, then you have strategies to reduce the sputum. If you have concomitant comorbidities, treat the comorbidities. If there are any treatable underlying causes, treat the underlying treatable causes. And then if there is a Pseudomonas infection, treat the Pseudomonas infections. And then those patients who have frequent exacerbations, you treat frequent exacerbations. That will come to it a little later. Yeah. So this is the stepwise management of non-cystic fibrosis bronchiectasis. Depending on the severity of the disease, the airway clearance techniques, long-term antibiotic therapy, anti-inflammatory therapy are applied in stepwise fashion in bronchiectasis patient depending on their severity. However, the general management approach to patients with bronchiectasis should include vaccinations against influenza and pneumococcus, manage comorbidities and underlying cause, pulmonary rehabilitation, prompt treatment of exacerbations, sputum surveillance for Pseudomonas aeruginosa and non-tuberculous mycobacteria should apply to all bronchiectasis patients irrespective of their severity. And a word about mucoactives. According to the British Thoracic Society, human DNase in adult bronchiectasis should not be routinely given, and the use of humidification with sterile water or normal saline to facilitate airway clearance is recommended. And if carbocysteine is prescribed, a 6-month trial should be given and continued if there is ongoing clinical benefit. And do not routinely give to bronchiectasis patients the following. Inhaled corticosteroid should not be routinely given. Long-term oral steroids should not be given routinely. Phosphodiesterase 4 inhibitors should not be given. Methylxanthines, leukotriene receptor antagonists, CXCR2 antagonists, neutrophil elastase inhibitors or statins. These are the ones that should not be given routinely to bronchiectasis patients. However, we'll come to neutrophil elastase inhibitor a little later. Now, coming to the microbiological prevalence across different continents in bronchiectasis patients, here we can see that heterogeneity is what we observe when it comes to microbes in the airways of the bronchiectasis patients. Haemophilus influenza more in Europe, Pseudomonas in Asia, Europe and USA, NTM and NTM in USA. So the point is, in bronchiectasis patients, several studies have shown that heterogeneity is the hallmark characteristic in microbiome composition, and a loss of bacterial diversity is associated with disease progression, worse lung function, and an increased number of exacerbations. However, there is not much data about the impact of viruses and fungi on bronchiectasis. So the common organisms associated with acute exacerbation of bronchiectasis are Streptococcus pneumoniae, Haemophilus influenza, Moraxella, Staphylococcus, and Pseudomonas aeruginosa. So wherever possible, treatment should be guided by antibiotic sensitivity, but we have to remember that there is in vivo and in vitro discordance when it comes to a response to antibiotics. So patients should be empirically given amoxicillin to begin with, and in case the patients do not respond to this simple drug called amoxicillin, then you can go for the sensitivity-based approach in the treatment of the pathogen in the setting of exacerbations. Okay, so because it has been said that some patients with infective exacerbation may respond to antibiotic treatment despite resistance to that drug in vitro, and antibiotics should only be changed if there is no clinical response. So once you isolate Pseudomonas aeruginosa, it is important to eradicate Pseudomonas because the morbidity and mortality due to this infection is very high in these patients. So there are about three various pathways that are described in the eradication procedure of Pseudomonas aeruginosa. Either you could start with oral quinolones and then give intravenous antibiotics and then go on to inhale antibiotics, or start with intravenous for 2 weeks and then inhaled antibiotics and then long duration antibiotics, or oral and intravenous together and then go on to inhaled antibiotics for 3 months. So there is no single strategy. So whichever, so each institute I think should adopt their own strategy of Pseudomonas aeruginosa treatment. The long-term treatment, that is more than 3 months of antibiotics, are reserved for patients with frequent exacerbations. So if a bronchiectasis patient has more than 3 exacerbations per year, then if it is Pseudomonas, the patient will give anti-Pseudomonal antibiotic, inhaled antibiotic, either colistin or aminoglycoside. Or if it is a non-Pseudomonas infection, long-term macrolide treatment is recommended for treating these patients. So whereas this is a meta-analysis of various the pharmacological and non-pharmacological therapies that were tried in patients to prevent exacerbations, clearly it is in favor of more macrolides. So macrolides are the drugs of choice in long-term treatment of bronchiectasis patients as an anti-inflammatory drug, because these macrolides have not only antibacterial, they have anti-inflammatory, anti-secretory, and they have tissue repair and healing. And then the cellular effects include they reduce the inflammatory cell migration to the airways, and they reduce the pro-inflammatory cytokines in the airways of the bronchiectasis patients. So far it was oral, intravenous, and nebulized antibiotics in the long-term treatment of antibiotics. This is a paper recently published which says the dry powder inhaled antibiotics could also be a possibility in days to come. And this study has shown that the patients who were given in dry powder inhaled antibiotics, where the number of exacerbations were reduced, quantity and virulence of sputum was reduced, even in the presence of Pseudomonas aeruginosa. So in days to come, maybe we are going to have inhaled dry powder antibiotics in the management of infections in Pseudomonas. So after discussing about the antibiotics and anti-inflammatory, now the mainstay of treatment in bronchiectasis is just physiotherapy management. Again, the strategies depend on whether what is the problem with this patient. Is it a mucus problem? Is it an exercise intolerance problem? Or is it a respiratory or a muscle weakness problem? So various strategies are applied for this to address each issue. If mucus is an issue, then postural drainage, taking gravity into consideration. If it is, or we can have a expiratory flow modification in the form of autogenic draining, or forced expiration in the form of active cycle breathing test, breathing and then cough, huffing, and then, or you could use instruments in the form of a flutter or an a cappella, which are positive expiratory pressure instrumental techniques in causing airway clearance. Exercise, if the issue is exercise intolerance, aerobic training, physical activity counseling and strengthening training. If the issue is muscle weakness, respiratory muscle weakness, inspiratory muscle training is what is recommended for these patients. Now coming to the exacerbation. For a long time, there was no single definition for exacerbation of bronchiectasis. So in 2016, bronchiectasis experts from Europe, North America, Australasia, and South Africa met together and came up with a consensus definition wherein they have said, if there is deterioration in 3 or more of the following key symptoms for at least 40 hours in a bronchiectasis patient, and a clinician determines that a change in bronchiectasis treatment is required, then you can label this as exacerbation of bronchiectasis. The clinical impact of bronchiectasis includes there is an increased airway and systemic inflammation. It is associated with progressive lung damage. There is accelerated lung function decline. The quality of life is poor. Hospitalizations are more, and there is increased mortality. And patients may exacerbate for multiple reasons. The endotype comes into play here. It could be eosinophilic inflammation, neutrophilic inflammation. It could be elevated sputum, neutrophil elastase activity, the immune deficiency, or it could be due to comorbidities or genetic susceptibility or microbial dysbiosis. So there is a phenotype called frequent exacerbator. Like in asthma and COPD, even in bronchiectasis, we have frequent exacerbators. And these frequent exacerbators are the ones who have more than 3 exacerbations in a year, and these patients have worse quality of life, more frequent hospitalizations, and increased mortality over 5 years down the line. So if you have a frequent exacerbator, and the treatment strategies would be airway clearance, vaccinations, prompt antibiotic treatment for exacerbations, and the antibiotics depend on the severity and response to the antibiotics chosen, starting from various pathways that we have already discussed to intravenous antibiotics every 2 to 3 weeks. Now, this is a molecule that is very interesting. This is a novel oral reversible inhibitor of a neutrophil elastase, and this study is phase 2 Willow study presented at ATS Virtual Clinical Conference in June 2020, wherein they have said that brensocatib, if given orally once daily for 24 weeks, the risk of exacerbation reduction is 42%. So 10 milligrams per orally when given to bronchiectasis patients, frequent exacerbators, then the risk of exacerbation is reduced by 42%. So this is an interesting molecule. We have to wait and see. Hope it passes through phase 3 trial, because as of now, we don't have a single drug to manage, single approved drug in the management of bronchiectasis. So the medical management of bronchiectasis is multi-pronged approach, depends on which phenotype, and so the targeted therapy or personalized therapy is what is applied in the management of bronchiectasis. It includes airway clearance, management of infections, rehabilitation, bronchodilators if there is breathlessness, steroids if there is an asthma or frequent exacerbation with steroid and bronchiectasis together, or ABPA, treatment of respiratory failure, vaccinations, IVIG replacement if there is immunoglobulin deficiency, treatment of GERD, rhinosinusitis, management of comorbidities, management of exacerbations, management of hemoptysis, management of carpal tunnel. These are all the various strategies that have to be applied in the management of bronchiectasis. Now, how do we monitor these patients of bronchiectasis? CT test is done at the time of diagnosis. Underlying cause identification should be done at the time of diagnosis. Comorbidity assessment should be done at the time of diagnosis, and various other parameters like BMI, exacerbation history, sputum cultures, MRC, dyspnea score, spirometry, and oxygen saturation should be evaluated annually if there is a mild disease, or 6 monthly if you have a severe disease. So various surgical options are available. Surgical resection in select group of patients, lung transplantation if you have a younger patient who have recurrent massive hemoptysis, bilateral disease, and bronchial artery embolization has failed, and if there is severe secondary pulmonary hypertension, lung transplantation is an option in such patients, and surgical resection, either lobectomy and pneumectomy, in select group of patients who have medically failed. So how do we prevent the development of bronchiectasis? It starts with in utero. The health of the mother is important for the health of the child. So all measures to be taken to prevent prematurity, because prematurity is associated with bronchiectasis. Postnatally, again, encourage breastfeeding and reduce overcrowding. Give vaccinations to these patients so that they do not develop frequent infections, and then the risk of bronchiectasis is reduced. And give the child healthy food. And if the patient has frequent infections in the childhood, detect the etiology cause for, and the socioeconomic status also should be improved, because low socioeconomic status is associated with chronic respiratory diseases, vitamin supplementation. So overall, the general health of the mother and child are important to prevent development of bronchiectasis. Now we'll go to overlap syndromes, bronchiectasis and COPD overlap. So prevalence of bronchiectasis in COPD patients ranges from 4% to 72%, and COPD patients that have evidence of bronchiectasis are usually older males, have more severe airflow obstruction, they have more sputum production, greater systemic inflammation, and isolation of sputum pathogen, especially Pseudomonas aeruginosa, is more. If there is a bilateral pan-acinar emphysema by lower lobe, alpha-1 antitrypsin to be looked for, and they have greater daily symptoms like sputum and frequent bronchial infections, lower lung functions, increased mortality, greater risk of developing pulmonary hypertension, and NTM infections are more in patients with the bronchiectasis and COPD patients. So the COPD patients, the recurrent infections will end up into this cold vicious cycle or vicious vortex, and then they develop bronchiectasis. So it is important to assess whether COPD or bronchiectasis is the primary diagnosis in order to guide investigative strategy and treatment. If the patient with primary bronchiectasis has fixed airflow obstruction, and this is to be taken as a marker of severity of the disease. If bronchiectasis is seen in a patient with COPD, then this should be considered as COPD phenotype. Or if for patients with both diagnoses who therefore have a true overlap, this is a situation where there is a true overlap. So in this, there is a need to understand more about this condition with specific regard to epidemiology, natural history, and treatment. Bronchiectasis and asthma. Bronchiectasis is frequently considered to be a consequence of long-standing severe uncontrolled asthma. Bronchiectasis is seen in 20 to 30% and are now being reported in cohorts with severe or uncontrolled asthma. Patients with severe asthma with bronchiectasis are often older and show more severe obstruction and higher rates of expectoration infection, may have worse prognosis than asthma alone. Asthma has been reported in about 3 to 8% of bronchiectasis patients, because bronchiectasis patients also do have bronchial hyper airway responsiveness as well. So bronchiectasis is more prevalent in patients with steroid-dependent asthma. Hypoglomaglobulinemia in asthma is associated with bronchiectasis. So although patients with severe asthma and bronchiectasis usually do not report tobacco exposure or neutrophilic airway inflammation, they usually have poorer prognosis in terms of exacerbations and response to asthma treatment, and often require a therapeutic approach typical of bronchiectasis, that is long-term antibiotics and chest physiotherapy. In general, it is sensible to suspect bronchiectasis in patients with severe asthma who show a poor response to high-dose inhaled corticosteroids and report chronic cough or expectoration, recurrent infectious exacerbations, aspergillus sensitization and neutrophilia in the sputum. Asthma, COPD, bronchiectasis is an unstudied triplet. Chronic rhinosinusitis and bronchiectasis are also another overlaps. Combination of chronic rhinosinusitis and bronchiectasis nearly universal in cystic fibrosis and primary ciliary dyskinesia patients. The prevalence of rhinosinusitis among patients with bronchiectasis varies from 34 to 75% in European countries and 10% in American population. More prevalent in idiopathy than in post-infectious bronchiectasis. An allergic tendency causing chronic rhinosinusitis and inflammation of the lower airways has also been suggested. Peripheral eosinophilia and high Ig are elevated in patients with chronic rhinosinusitis and bronchiectasis, and the choice of treatment in such patients would be inhaled corticosteroids. So phenotype of chronic rhinosinusitis and bronchiectasis may be a distinct subgroup in which inhaled corticosteroids may be prevalent. In this group of patients, Pseudomonas aeruginosa colony is also seen more frequently to the tune of 30 to 35%. Rheumatoid arthritis is another autoimmune disease where bronchiectasis is more common. Among the 6 different European center cohorts of bronchiectasis, 1 to 23% of patients had a diagnosis of rheumatoid arthritis, which is about 8% again in US registry. So patients with bronchiectasis are more symptomatic, and more the bronchiectasis and rheumatoid arthritis, they have higher the mortality compared to just idiopathic bronchiectasis syndrome alone. So the relationship between bronchiectasis and rheumatoid arthritis could be bronchiectasis can predispose to rheumatoid arthritis, or bronchiectasis or rheumatoid arthritis during the progression can cause bronchiectasis, or bronchiectasis and rheumatoid arthritis may coexist simultaneously. So the Bros syndrome or bronchiectasis and rheumatoid is associated with greater immune activation and systemic inflammation, and treatment with biologics, DMARDs, doesn't increase the risk of severe pulmonary events in patients with rheumatoid arthritis and pre-existing lung disease. However, certain strategies like giving anti-TNF in patients with rheumatoid arthritis with bronchiectasis, there could be increased risk of pulmonary infections. This is an interesting small study where a small study was done wherein 16% of rheumatoid arthritis patients with diffuse bronchiectasis were heterozygous for delta F508 mutation of cystic fibrosis gene, regardless of sweat chloride concentration. So possibly there is a CFTR gene mutation in some of the rheumatoid arthritis patients. So idiopathic bronchiectasis associated with NTM. This is a group of patients who are usually post-menopausal women, non-smoking women. They present with a dry cough, and they have a typical physical characteristics. They are tall, asthenic, morphometric, scoliosis, pectus excavatum, and these features are also seen in first and secondary relatives of these patients with NTM infections. As we have already discussed, these are the patients who have ciliary variants or immune variants or connective tissue variants or cystic fibrosis variants, and MAC pulmonary disease presenting as isolated lingular or right middle lobe bronchiectasis is labeled as Lady Windermere syndrome. And this is a study published in Korean journal wherein they have looked into the impact of bronchiectasis on post-operative pulmonary complications, non-thoracic surgeries. Clearly, they have shown the post-operative pulmonary infections are overall more in patients with bronchiectasis than without bronchiectasis. There are various risk calculators for predicting post-operative pneumonia or respiratory failure, like Aerozola or Gupta, Aricot or Periscope, but none of them are specifically for bronchiectasis. So there is a knowledge gap here. Now, how are we managing patients of bronchiectasis? This is a paper published from a tertiary center in Australia. So this is bronchiectasis patients being taken care in a tertiary care center in Australia. So what they have found is, even though 67% of the patients were eligible for pulmonary rehabilitation, only 22% of them attended rehabilitation. Airway clearance, even though it was indicated for 71%, only 52% of them availed. Sputum bacterial cultures were available only 59%. Mycobacterial results were available in only 29% of the patients. Inhaled antibiotics were used in half of potentially eligible patients. Despite guideline recommendations against current use, inhaled steroids were used in about 48% of the patients, and long-term macrolide were used in just 28% of the patients. This only tells us that there is a lot to be done in the management of bronchiectasis. If this is the situation in country like Australia, I'm sure we are no better. So to conclude, bronchiectasis is no longer a neglected disease. Interest and awareness are increasing in scientific and patient communities, and so is the CCI. That's why this topic they have chosen. So it's a bronchiectasis is a heterogeneous disease. It's increasing in prevalence. The hospitalization due to bronchiectasis is increasing. There is a huge knowledge gap in terms of epidemiology and pathophysiology. As on today, there is no licensed treatment for bronchiectasis. The treatment strategies are mainly extrapolated from cystic fibrosis or COPD based on expert opinion, and high quality evidence is still missing. As on today, chest physiotherapy and antibiotic treatment when an exacerbation occurs remains the cornerstone of bronchiectasis therapy. Discovering the underlying etiology of bronchiectasis could make a real difference in the management of prognosis of patients and could delay the progression of the lung involvement when treated adequately. And current guidelines recommend using clinical judgment and recognition of patient phenotype to guide testing for disorders such as cystic fibrosis, primary ciliary dyskinesia, or NTM can be reserved for those patients who are not responding to the conventional treatment strategies. Thank you very much for your patient listening.
Thank you so much, Paramjyoti sir, for an excellent talk on bronchiectasis. I'm sure all of us are thoroughly enchanted and enlightened with this wonderful presentation of yours. I thank you once again, and I keep the forum open for a question-answer session. After this wonderful talk, I hardly doubt anybody will have questions, but I can see we have more than 100 questions by our audience. So we'll take them up one by one. Can we start, sir?
Yeah, sure. Thank you, Bansal. Yeah.
Yes, sir. So the first question is by Dr. Alok Das, sir, from Raipur. He asked us, what are the symptoms of bronchiectasis, the most common cardinal symptoms of bronchiectasis?
Most of the bronchiectasis patients come with recurrent respiratory infections, cough and sputum being the most predominant symptom. So anyway, it's a heterogeneous disease or complex disease. So it depends on the comorbidities and the treatable traits. So by and large, recurrent infections, cough and productive sputum with hemoptysis sometimes, or sometimes patient may just have cough and then hemoptysis. They could be asymptomatic for a long time. They would have had tuberculosis some time back and then asymptomatic. Suddenly they come up with hemoptysis. So it is a Zika. So if it is dry bronchiectasis, they can present with hemoptysis. Or the most common would be cough and sputum production. Yes. The recurrent.
Yes, sir. And all these patients would generally be emaciated. They'll also have a long-standing history of weight loss and protein energy malnutrition. So I hope Dr. Das is satisfied with sirs and my answer. The next question is by Dr. Pooja Mishra from Ambikapur. So she asks us that why is bronchiectasis more common in men as compared to women?
By and large, the common cause of bronchiectasis, especially in India and globally, is infections. So infective, and then among the infections, tuberculosis is the topmost infection that causes bronchiectasis. So, and then tuberculosis more in men. So infections, men, and then smoking history also contributes COPD, bronchiectasis. So men in developing countries, but in developed countries, it has been realized that it is women who are getting more and more bronchiectasis, post-menopausal women. Possibly there is an autoimmune process that is responsible for bronchiectasis in women in developed countries. That could also be a scenario in India in days to come when once infections are no more the common cause of bronchiectasis. So as long as infections are common cause of bronchiectasis, as long as tobacco smoking is a common habit, bronchiectasis more in men as compared to women. In in our country and in developing countries. In developed countries, it is already, as I told you, it is women due to possibly autoimmune disease more in.
Also, the fact that gastroesophageal reflux disease is more common among men in our country, that also could play a contributory factor to the increase in incidence of bronchiectasis among men in our country. Thank you, sir, for that answer. The next question is by Dr. Partha Pratim Roy from Kolkata. So he asked us that what are the changes in the approach in recent times to bronchiectasis patients? What are the changes in our approach and our clinical outcome in bronchiectasis?
The awareness has increased about bronchiectasis in India, and so that's why we are here discussing about this topic. So the suspicion of bronchiectasis should be very high in any patient who have productive cough with sputum. I mean, so more than 8 weeks, if they have this productive cough sputum, then we have to keep in mind bronchiectasis. So, and any patient with risk factors, say for example, asthma patients with productive sputum with Pseudomonas, COPD patients with productive cough sputum, Pseudomonas, or rheumatoid arthritis, or inflammatory bowel disease. So all these patients who are risk, or those who had past history of tuberculosis. So in these patients, bronchiectasis has to be suspected, and it is more and more being suspected also. And now that we have HRCT available, being the gold standard for diagnosis of bronchiectasis, so that has also made up the diagnosis of bronchiectasis more. So awareness is more, diagnosis is more, especially thanks to HRCT. So I think these are the two things that made us make diagnosis of bronchiectasis more and more.
Yes, sir. Thank you. Thank you so much for that wonderful answer. The next question to us is a very important question, and I'm sure you will address this in your talk, sir. It's by Dr. Amarjeet from Bhatinda. So he asked us that can we use steroids? So I'll divide this question into two parts, sir. Can we use A, inhalation steroids in bronchiectasis, and B, can we use oral corticosteroids in cases of bronchiectasis?
Yeah. So if we read the European Respiratory Society guidelines for management of bronchiectasis 2017, they have very categorically said that inhaled corticosteroids or oral corticosteroids for bronchiectasis should not be given for every patient. However, there could be some subset of patients where inhaled corticosteroids could be beneficial, or oral steroids could be beneficial despite they having bronchiectasis. Say, for example, asthma patients with bronchiectasis. So we have to treat asthma separately, and so the treatment of choice in asthma would be inhaled corticosteroids. So we have to give inhaled corticosteroids in that group of patients despite they having bronchiectasis. COPD patients with bronchiectasis. COPD patients with bronchiectasis who are having recurrent exacerbations, severe COPD with recurrent exacerbations, they are candidates for steroids, so inhaled steroids. So we have to continue to give inhaled corticosteroids despite they having bronchiectasis. Or asthma ABPA or bronchiectasis ABPA, if there is an asthmatic component there, eosinophilic inflammation, IgE elevated, despite bronchiectasis, inhaled corticosteroids have to be given, or sometimes oral corticosteroids also have to be given along with antifungal, especially if we are dealing with ABPA. Of course, ABPA I did not discuss here because it's a separate disease altogether. So these are situations where inhaled corticosteroids can be given, or if the patient has an autoimmune disease like rheumatoid and then bronchiectasis, and if they have to steroids, so steroids have to be given there. So depending on what is the comorbidities, the steroids have to be given depending on what we are dealing with, irrespective of bronchiectasis.
Yes, sir. So I'll just summarize it. What sir has been trying to tell us is that bronchial asthma, COPD, ABPA in short, coexisting with bronchiectasis, please go ahead for inhalation steroids, and SOS, oral corticosteroids. I think that sums it up. So the next question is a very important question that is asked to us by Dr. Agarwal from Jhansi, is that are we seeing increased incidence of bronchiectasis in these recent COVID-19 times? I think it's too soon to tell, but I'll hand it over to you, sir.
But yeah, it's too early for us to comment. But anyway, we are seeing more and more of fibrotic lung diseases, fibrotic interstitial lung disease, COVID-19. So we would expect more of traction bronchiectasis in this group of patients. So yes, we expect to see more of traction bronchiectasis in this COVID-19 patient, especially if they have been very sick with pneumonia, and then if they've gone into ARDS and on ventilator and a lot of fibrosis. So fibrosis, traction bronchiectasis, I think we are going to see more and more in days to come.
Yes, sir. I completely agree, because as of now, the only picture or pattern which we are seeing in a post-COVID setup is organizing pneumonia, followed by fibrotic lung disease, like you rightly said, and pulmonary thromboembolism. These are the three main things which we watch out in a post-COVID state. Now, coming back to bronchiectasis, I have a very valid question by Dr. Sharik from Hyderabad. So, sir is asking us that how many infections, that is the minimum number of infections required for a patient to develop bronchiectasis? I think it's a very good question, sir.
How many infections? Well, so it starts with childhood, repeated infections. Repeated infections in children would lead to bronchiectasis. Or if the patient has tuberculosis, with traction bronchiectasis. So one infection of a pulmonary very bad tuberculosis infection can cause traction bronchiectasis, or repeated infections. So I don't think there is any number of infections. Well, to diagnose primary immunodeficiencies, there are certain infections, number of infections, and then CSOM and all that stuff. But a single infection also can cause bronchiectasis. Yes, if there is repeated infection, chances are more. Yeah, depends on the pathogen and the immune status, nutrition, habits, and all those things put together. Yeah.
So safe to say that a single tubercular or a single fungal infection can cause bronchiectasis, whereas multiple viral and bacterial infections will predispose an individual to develop bronchiectasis. Yes, you rightly pointed, but a very good question by Dr. Shari.
Now, this bronchiectasis is also described. So if there is a measles of one measles attack, and then they
yes sir, they can have, yes sir. So now the next question is by Dr. Suresh from Trivandrum. He's asking, what is the most common infection in bronchiectasis? I'm sure he's meaning what is the most common pathogen associated with bronchiectasis.
By and large, worldwide, the common pathogen would still be Streptococcus pneumoniae or Haemophilus influenza. Yeah, these are the common bacterial that are isolated even during exacerbations. That's why the first drug of choice would be to give amoxicillin, amoxiclav, and then look for the response. So Pseudomonas, yes, it is a pathogen. That's other pathogens can also be a possibility, but the common pathogens would still be Streptococcus or Haemophilus influenza.
Yes, sir. Probably in our country, tuberculosis would be a risk factor for bronchiectasis, but the most common pathogen isolated in bronchiectasis patients, like you rightly said, would be Streptococcus, Haemophilus, and we all hope it's not Pseudomonas. But yes, the trend for Pseudomonas is definitely on the rise. Yes, sir. So now we have another question from Dr. Vishwabandhu Gurdasani from Kutch. So sir is asking us, what is the best prophylaxis for chronic infections in bronchiectatic patients?
Prophylaxis is to prevent an infection.
Yes, sir.
Vaccines would be the best bet to prevent any infections. So, however, the lifestyles do matter to prevent infections. Healthy lifestyles, diet, vaccinations, and of course, not getting exposed to tobacco smoke or environmental pollutions. These are some of the things. And
yeah. So I think regular adherence and compliance with medication, regular follow-up with your chest physician in a case of bronchiectasis, annual vaccination with influenza, and pneumococcal 13 followed by pneumococcal 23 vaccination, along with a good pulmonary rehabilitation program, I think should suffice in management of cases of chronic bronchiectasis.
The question for bronchiectasis or general?
For bronchiectasis, sir. Just for bronchiectasis.
Okay. So for that, again, yeah. So vaccinations and chest physiotherapy and lifestyle modifications. Yeah.
Yes, sir. The next question is by Dr. Abhinav Chaudhary from Lucknow. So he is asking us, what is the role of azithromycin in bronchiectasis, and how long can we give azithromycin in bronchiectasis?
So azithromycin, as things stand today, it is not only an bacterial, it also has an airway immunomodulatory action. So azithromycin is recommended for those bronchiectasis patients who have frequent exacerbations, that is more than 3 exacerbations per year. If they have non-pseudomonal infections, then azithromycin is the drug that is recommended by all the guidelines. And it is usually given in the dose of 250 to 500 milligrams, 3 days in a week. And then you can go on to give for more than 3 months, 6 months. But make sure that we are not dealing with any atypical mycobacterial infections before you start macrolides. Make sure that there is no cardiac pathology, especially acute interval. So ECG should be okay. We should not. We should have ruled out NTM infections in these patients. Yeah. So azithromycin is for non-pseudomonal frequent exacerbator. But sometimes those patients who have Pseudomonas infections, if they fail to inhaled drugs like say colistin or tobramycin, then also azithromycin can be tried. So that way azithromycin is both for non-pseudomonal and pseudomonal if they fail the colistin or tobramycin.
Yes, sir. Thank you for this wonderful thing. And now, since we're on the same topic, we have a similar question. The question is asked by Dr. Mishra. What is the role of inhaled antibiotics in cases of bronchiectasis? So we'll continue with this discussion.
Yeah, so inhaled antibiotics is, say, for example, inhaled antibiotics for pseudomonal infections. That's the first line of treatment. Inhaled antibiotics usually is through nebulizer as things stand today, either colistin or tobramycin. But then there are some encouraging reports suggesting that dry powder antibiotic inhalers are also going to be useful in these patients. So as things stands today, nebulizer is the way to give inhaled antibiotics, but dry powder inhalers also can be given. So tobramycin and colistin, tobramycin is the most common inhaled antibiotic that we are giving for especially pseudomonal eradication program.
Yes, sir. And the next question is by Dr. Kazi from Array. He asks us, what is the duration of treatment with inhaled antibiotics in bronchiectasis patients? Yeah. And what is the dose?
So inhaled antibiotics, yes. So we are giving tobramycin inhaled antibiotics twice a day, and then we give it for more than 3 months, 6 months. So 6 months should be fair enough. But then we have to be very careful that they are not getting any other nephrotoxic drugs. We are closely monitoring the creatinine levels, and then of course phototoxicity because they are aminoglycans. So we have to be very conscious of these things. Yeah.
Yes, sir. So tobramycin would typically be 300 mg, which comes in a 5 ml respule to be given twice a day. So multiple studies tell us that you must use a 28-day on, 28-day off cycle over 6 months. So you can give
cyclic.
Yes. Yeah. Cyclical giving tobramycin. So you can give it twice a day for 28 days, followed by a 28-day cooling period. And with respect to colistin becomes a slightly expensive drug in our Indian setup. So probably the dose would range from anywhere between 1 MIU 3 times a day to 2 MIU 3 times a day, depending on the tolerability of the patient. And also something which we need to watch out in these cases is probably epistaxis, which becomes a very common issue in inhaled antibiotics, whether there's any bleeding from the nose. So that's something which we should look out for.
Yeah, and then also watch for any development of drug resistance.
Yes, sir. Yes.
There are no reports of drug resistance being reported, but however, be watchful for development of any drug resistance if we have to continue for a long time.
Yes, sir.
Or if the patient is ready. Okay.
Yes, sir. So the next question is by Dr. Jamal from Delhi. Sir is asking us, how do we manage a case of exacerbation of bronchiectasis?
Exacerbation of bronchiectasis is by and large due to bacterial infections generally. So we have to give them antibiotics and then chest physiotherapy. By and large, there are no approved drugs to treat bronchiectasis. It is infection control and airway clearance. So infection control in bronchiectasis is usually bacterial, and the common pathogens, as we have already discussed, is Streptococcus or Haemophilus, and amoxicillin or amoxiclav would be the drug of choice. If you cannot give it amoxiclav, you can give either doxycycline or a macrolide. So amoxiclav antibiotics that way, and then of course chest physiotherapy, and then postural drainage. And if the patient is too sick, then if the patient has any respiratory failure, if he has not much of secretion, then you can give NIV and oxygen, or the supportive care can be given. So antibiotics, chest physiotherapy, and other supportive measures still remain the gold standard in the treatment of exacerbation of bronchiectasis.
Yes, sir. Thank you. Now, Dr. Anil Gupta from Yamunanagar, Delhi asked us that what do we do in a case of long-standing bronchiectasis with a productive cough, but the productive cough is sterile in nature? So how do you manage constantly copious amounts of sputum in bronchiectasis?
So those patients, where the problem of mucus production or sputum production is more, physiotherapy, postural drainage, and then you have PEP devices like a cappella. These are the mainstay of treatment, having ruled out any chronic infections. If there are any chronic infections, and then the approach would be the treatment with antibiotics. If there are no infections, it is just simple mucoid. It is still airway clearance strategy that should be stressed on.
Yes, sir. So airway clearance techniques, chest physiotherapy, continuous postural drainage, then positive expiratory pressure devices, your a cappella, high frequency chest wall oscillation devices, inspiratory muscle training, expiratory muscle training, and constantly having 4 to 6 cycles of coughing till the entire sputum is cleared out. All these maneuvers will definitely help in cases of sterile sputum, because the sterile sputum eventually will get accumulated and become infected. That would be our vicious cycle of bronchiectasis, the Coley cycle. So it's very, very important that we get rid of the sputum, whichever is stuck inside. So a very, very valid question by Dr. Gupta. Now,
10 to 30-minute session twice a day, or until the sputum becomes colorless or less sputum comes. So they have to regulate.
Yes, sir. Now we have Dr. Shukla from Guwahati. So sir is asking us, is bronchiectasis hereditary? Can it be passed on?
I mean, we still do not know the genetic factors, but yes, there are some genetic factors that are linked, and then there are certain families where there are certain inheritable factors like connective tissue. They are seen more in first and second degree relatives of patients with, say, Marfan's or Ehlers-Danlos syndrome. So in such situations, yes. And cystic fibrosis variants are noted in rheumatoid arthritis patients, even in idiopathic bronchiectasis patients. So we are beginning to understand the endotypes of bronchiectasis. So some of the endotypes, are they inherited? Possibly, yes, we still do not know, but some of the connective tissues are inherited, like Ehlers-Danlos or in first and second degree relatives with bronchiectasis.
Yes.
Yeah, so some genetic polymorphisms are also described where they are more prone for infections, repeated infections, and bronchiectasis.
Thank you, sir. Now we have a next question by Dr. Sujata Sarda from Latur. So she asked us that what is the role of bronchoscopy in patients with bronchiectasis?
Well, bronchoscopy, if there is a focal bronchoscopy, we look for whether there is a foreign body or a tumor or a stricture or a malacia, or to take bronchial washings or alveolar lavage, what is the pathogen, whether it is NTM or Pseudomonas, what is the pathogen that is there? Is there bronchomalacia? If there is a roomy airways with the diverticula, then it's the second, third airways are collapsing, then it is bronchomalacia. It could be William Campbell syndrome. So you can make some diagnosis of this nature. You can also pick up infections.
And sometimes it just helps in airway toileting, sir. I mean, the thick secretions which are there, it just sometimes helps in airway toileting. The patient instantly feels better after doing a bronchoscopy. I think that's the only situation when patients thank us for doing a scopy.
Many times, yeah, that's our experience. Many times they feel very happy that they have some procedure was done and they feel very happy. Yeah, that's true. I agree. It's a common experience. Yeah.
Yes, sir. Yes, sir. So the next question is asked us by Dr. Tarmarkar from Latur. So sir is asking us, what is the role of lung transplantation in bronchiectasis and what is the prognosis of lung transplanted patients in bronchiectasis in our country?
So the lung transplant surgeon should be talking on this topic. But yes, if it's a bilateral disease and progressive disease and recurrent hemoptysis, severe pulmonary arterial hypertension, they are younger patients, their life expectancy is more. I think lung transplantation should be an option given to these patients now that more and more lung transplants are being done in our country.
So I think the core thing would be that the patient should be less than 65 years age and an FEV1 should be less than 30% for him to fit the criteria.
Severe impairment in lung function, young patients with pulmonary arterial hypertension and bilateral disease, extensive disease, hemoptysis massive despite multiple bronchial artery embolizations. So these are the patients.
Yes, sir. The next question by Dr. Kinjal from Jamnagar is that how does the treatment of dry bronchiectasis differ from normal bronchiectasis, that is wet bronchiectasis?
Well, the presentation of dry bronchiectasis is by hemoptysis. So it depends on the amount of hemoptysis they have. And sometimes if there is a mycetoma, they can also have massive hemoptysis. So if it's a focal disease, younger patients, massive hemoptysis with a mycetoma, I think surgery would be an option. If they are not surgical candidates, and bronchial artery embolization would be the other option to control hemoptysis in these patients. So if there is a mycetoma, dry bronchiectasis, massive hemoptysis, surgery would be better in this patient if they are surgically fit enough. Otherwise, bronchial artery embolization is another option for these patients.
Yes, sir. So the next question asked to us by is Dr. Grover. So Dr. Grover is asking us that what is the role of pulmonary rehabilitation in bronchiectasis?
So like COPD, every chronic airway disease patient should undergo rehabilitation. So, but then unfortunately that aspect is very much neglected, at least in our institute. There is no program of pulmonary rehabilitation for bronchiectasis patients. Yes, so rehabilitation should be one of the main modes of managing these patients. Physiotherapy, rehabilitation, vaccinations, so all these things. But then as I have shared in my presentation, Australia, where in spite of their being eligible, quite a few of them are not taking part in the rehabilitation. So if it can happen in the developed country like Australia, I think rehabilitation in India still, I mean, we have to push for it, yes, but it helps the patient as we understand. Yeah.
Yes, sir, you rightly said, and a very valid question, because even most tertiary care centers in Bombay, including ours, we don't have a dedicated rehab program. So this is something we need to create more awareness from, because not only COPD, asthma, but bronchiectasis patients also require a very, very strong rehab program, because that's the way only the quality of life would increase.
Yeah.
You're rightly saying.
Now that as I have already told, there is no approved drug for bronchiectasis. So the mainstay of treatment is still airway clearance and rehab.
Yes.
Prevention of exacerbation, whatever it takes, so that the daily symptoms are less and exacerbations are less, quality of life is better in this group of patients. Yeah.
Dr. Banerjee from Bulgaria is asking us that how common is depression and what is the psychological stress in patients among bronchiectasis?
Well, it is described, textbooks have described, but we have not specifically looked into depression in bronchiectasis in our group of patients. COPD, yes, we have done some study. OSA patients, we have done some study, but then in bronchiectasis, but it is described. So I have no personal experience of this in our bronchiectasis patient, but it is described in books.
Yes, sir. Now we have a question from Coimbatore by Dr. Bhalla Subramaniam. Now, sir is asking us, what is the best inhaler for patients with bronchiectasis? If you have to pick one inhaler, what would you do?
No, the inhaler medication for these patients is to relieve breathlessness. The bronchodilators are the drugs that are prescribed for these patients if they have breathlessness. And if steroid is indicated for some reason, they can give bronchodilator and inhaler combination. Yes. So to relieve breathlessness, bronchodilators, LABA, and if there is an asthmatic component or steroids have to be given for some other reason in these patients, ICS, LABA would be an option for this group of patients.
Yes, sir. Now we have a very interesting question by Dr. Tridib Chatterjee, sir, from Mumbai. So, sir is asking, should we use a mesh nebulizer for nebulized antibiotics, or we may get a poorer response with a conventional nebulizer?
Yes.
So, is a mesh?
Yes, ideally yes, but it's not very practical in our setup. So some of our patients, I mean, they are poor patients. As such, the drug is so expensive. So ordinary nebulizer, the efficacy is little less. But if they can afford a mesh nebulizer, that's great.
Yes, sir. Now, another question in a slightly different way by Dr. Banerjee from Bulgaria is that what is the ideal duration of macrolide therapy? The long-term macrolide therapy, how long should we continue it and when should we stop it?
No, the macrolides for bronchiectasis is for say 6 months. People have also given up to 1 year also. So it depends on how many exacerbations that they have been having while on this drug. So if the exacerbations have come down, you can take a chance and then stop the drug. I think the maximum the azithromycin is given would be for 1 year, but 6 months.
Yes, sir. But then can we extend it beyond 1 year, sir? If we stop it and we see that the patient is having recurrent exacerbations, but when the patient is on macrolide, his number of exacerbations are less than 3 per year. So can we just continue it? Maybe 3 times a week, it's a safe drug relatively.
Yeah, if there is no issue with the cardiac issue or drug resistance issue, patients are improving, I think we can give for a longer time. Yeah. So this is a good immunomodulator, and this is also a poor man's biologic in severe asthma patients also. It works even in severe asthma patients.
Thank you, sir. Now the next question is by Dr. Dhancha from Latur. What are the role of vaccines in bronchiectasis? How important is vaccination?
Yeah, because bacterial infections, possibly viral infections are also one of the cause of exacerbations of bronchiectasis. So if we can prevent either viral infections and common being Streptococcus pneumonia, and the vaccine that is available is fairly efficacious in Streptococcus pneumonia, so they have to be given to bronchiectasis patients, both viral and against pneumococcal vaccine. So pneumovac, and then with the polysaccharide, and then conjugate it with the spacing, and then yearly influenza vaccine have to be given for this patient. That's a very good preventive strategy across all severities of bronchiectasis.
And I think not just bronchiectasis, among all chronic respiratory diseases, the same thing should be followed, the same protocol for vaccination. Yes, yeah. Thank you, sir. Now we have an important question by Dr. Desai. Now Dr. Desai is asking us that what is the role of cough suppressants in bronchiectasis? Should we use cough suppressants?
No. If the patient has dry bronchiectasis, and if the cough is really bothering him, and if the patient has hemoptysis, maybe you can, for a very short period of time, try to suppress the cough. You can give cough suppressant in that situation, but otherwise, it is always expectoration, and so cough suppressants, to me, is an indication only if it's a dry bronchiectasis with hemoptysis, and for a short duration of time.
I completely agree, sir.
NTM patients also have dry cough. So if it is really bothersome, then you can give in that scenario also.
Yes, sir. Because otherwise, the whole point of airway clearance and expectoration of the sputum is lost if we use a cough suppressant. That would give the patient temporary relief, but in the long term would increase the colonization of the bacteria and further cause an exacerbation. So yes, let us avoid cough suppressants wherever possible, unless it's a dry bronchiectasis, like you rightly said, sir. So we've come to the end of questions, sir. We have almost answered more than 30 questions. Majority of them were repeat questions from a lot of our doctors. I thank you wholeheartedly, Paramjyoti, sir, for being so receptive and answering each and every question with utmost grace and clearing all our doubts, and of the doctors attending this wonderful webinar by you. I deeply, deeply thank you, sir, for sharing your time and being so patient with us and educating us all. And we've learned a lot from you, sir. At the end, I would also like to thank CCI once again for giving us the opportunity to interact on such a large scale with the entire audience and speak and discuss on bronchiectasis. CCI Chairman Trustee, especially Narayana Pradeepa sir and NH Krishna sir, our coordinator Chenam Chetty sir, and our office bearers, Narendra sir and Ravi Doshi sir. Thank you so much, and definitely Cipla for organizing this event so beautifully. Such a hassle-free platform for us to communicate and deliver talks and take questions from everybody. Thank you so much. Thank you. I hand it over to you,
Thank
Param
you,
Jyoti.
thank you, Dr. Bansal, for moderating this session, and you have been just brilliant. And once again, I would again repeat what all you have said, that I have to thank President Krishna Garu of CCI and all the esteemed office bearers of CCI who have given us this opportunity to talk a few things that I know about bronchiectasis, and of course Cipla also for helping in the webinar. So thank you once again, entire CCI team. I really cherish this moment, and I'm going to do this for a very, very long time. Thank you very much.
Perfectly said, sir. Perfectly said, Param Jyoti. So we're going to all follow your footsteps. Thank you so much. Thank you, everybody. Thank you. Good night.